Thank you, Jolie. And I want to just say thank you to everyone. It's so exciting to have this large group to today's presentation on understanding eating disorders as anxiety disorders, the role of fear and the need for safety. As Jolie mentioned, my name is Molly Schlapp-Gilgoff, and I'm the manager of mission initiatives at the National Eating Disorders Association. And we're so excited to be collaborating with the Anxiety and Depression Association of America on this webinar today. Before we get started, I'd like to just take a brief moment to talk a little bit about the National Eating Disorders Association and the work that we do. NEDA is a nonprofit organization working to fundamentally change the way that eating disorders are understood and treated, and to empower those affected to achieve lasting well-being and recovery. Through campaigns like Eating Disorders Awareness Week, which is taking place this week, and through our Campus Warriors program and NEDA Cares events, we are working to increase public understanding of these complex disorders. We also provide information and resources through the Grace Holland Cosine Resource Center, as well as through our educational programs like the Understanding Eating Disorder presentation and webinars like this one. Additionally, we promote early intervention through our screening tool, which has helped over 1 million people. We also have invested in groundbreaking research that helps to develop effective treatments. To learn more about NEDA and our resources and initiatives and all that we do, you can visit the website linked on this slide and also the QR code for easy access. I'd now like to introduce our esteemed presenter, Dr. Norman King. Dr. Kim is a member of NEDA's National Clinical Advisory Council and the inaugural Diversity, Equity, and Inclusion Officer for the Center for Practice Innovations at Columbia University Department of Psychiatry and the New York State Psychiatric Institute. He is also adjunct faculty in the New York University Department of Applied Psychology and the co-founder of the Institute for Anti-Racism and Equity, a social justice-focused consultancy. Thank you so much, Dr. Kim, for being here, and I'll hand it over to you.
Great, thank you, Jolie and Molly. Let me see if I can get my slides up. Okay, so hopefully everyone can see that. Yeah, since we're sharing weather, I'm here in New York City. We are in the season that we affectionately refer to as fake spring or fool's spring. We're having like about a week of somewhat warmer weather, and then there's undoubtedly going to be colder weather coming back. So I'm trying not to get my hopes up too high here. I'm very happy to be here with you all on behalf of NEDA, the National Eating Disorders Association, as well as the Anxiety and Depression Association of America. As Molly mentioned, I'm currently the DEI officer for the Center for Practice Innovations at Columbia. More importantly, for the purposes of this presentation, I've worked with people struggling with eating disorders and anxiety for well over 20 years. And that's really been my primary clinical focus area. Clinically, I have found that taking an evolutionary psychology-based approach that is trying to understand the origins and the adaptive functions of various psychological characteristics and disorders, and then a related approach referred to as taking a transdiagnostic approach, which looks at commonalities among diagnostic entities rather than focusing on their differences. I find that both of these approaches are particularly for larger psychological entities like shame and anxiety and eating disorders, which are so often at the root of what so many of us struggle with, that kind of approach can be extremely helpful in understanding these phenomena better. I've been using that framework in much of my work. I was the co-founder of a national eating disorder program, and I also advise various companies and startups in the US and in Europe. And I found it to be a really useful way to think about these illnesses. So let's start at the level of behavioral presentation. Eating disorders can often be very perplexing and confusing to not only families, but certainly also to practitioners, not to mention the people who are afflicted by this illness. They're complicated illnesses that require multifaceted treatment approaches, multiple focuses of treatment. And to me, one of the more interesting things, just from a diagnostic perspective about eating disorders, is its consistency in how it's presented and in its history. There are descriptions of what would easily be recognized as anorexia nervosa or bulimia nervosa in the very first Greek and Arabic medical textbooks that exist. The ancient Romans and ancient Egyptians had entities that we would again very clearly recognize as eating disorders, and that's not true for most things that we would look at. You know, for anxiety, depression, schizophrenia, most of the more modern psychiatric diagnoses that we tend to use and that we diagnose people with, even though they might have some antecedents historically, we don't see the kind of consistency in their presentation from both from culture to culture, but also across time. So that tells us something interesting about this illness. There's something about the illness that is, I think, sort of rooted in some natural part of how we're all sort of wired, for lack of a better word. And so I want to start with a couple of historic examples just to illustrate that, and I think it tells us something important about these illnesses. I went to 12 years of Catholic school, so St. Catherine was certainly somebody I was familiar with as a personage, and I later came to understand her importance in the context of understanding eating disorders. She was a 14th century ascetic mystic, Catherine of Siena. She was reported to engage in extreme fasting behavior, purging, and consequently actually died because of those behaviors. She saw herself in the thinking of the time as becoming more Christ-like through her suffering. It's a very old idea, and it's an idea not necessarily tied to religion now, but it's an idea that strength comes from restriction. Strength and virtue come through sort of making one suffer by denying yourself things that other people might need. That's an idea that carries forward to this day, and that so many people struggling with this illness really have going on internally. I want to tell you a little bit of some of what we understand about her as a person, because again, I think it tells us something about this illness. Her mother had 25 children in total. Almost half of them died during infancy, which again, understanding this was the 14th century was not terribly uncommon. She was said to be a perfect, very happy and joyful child. When her older sister died during her childbirth, 16-year-old Catherine was pushed by her parents to marry her sister's widow, which was something she was absolutely opposed to. So I want to take a second to think about this was a girl, not to mention a girl in the 14th century, making this kind of stance, which was just really unheard of at the time. That should tell you something about sort of what kind of intrinsic personality characteristic Catherine had, even especially I think for her time, that she was able to say, no, this is not something I want to do. So interestingly, what she learned to do from the same sister was she went on a hunger strike. She went on a fast as a way to protest her husband's treatment of her. And it taught Catherine the power of fasting, the power of this behavior. That then manifested further into cutting off her hair as a protest against her parents, who wanted her to improve her appearance so that she could attract a husband, which was something she was not interested in doing. And it gradually developed into this very ascetic lifestyle. She gave away her food, her clothing, other items, and she lived in almost total silence and solitude. Now, it's also important to understand that even at the time, other religious people who knew her at the time, even to them, her behavior, they would describe her behavior as being quite extreme, even for other people practicing asceticism. So it tells us something that is very driven in its nature. It tells us how sort of deeply embedded this was in just who she was as a person. That it was something that managed to transcend sort of the social norms of the time, so that such that she was someone who really became known for these kinds of behaviors. Like I said, eventually she became unable to even swallow water, and eventually lost the use of her legs and passed away from complications. So if we take her out of this historical context, there's no question that if this was somebody coming to any one of our clinics, that we would very likely diagnose her as having anorexia nervosa. And with almost nothing else other than what we know about her historically, it's a diagnosis that would be very consistent from then till now. In the 1600s, Richard Morton wrote his treatise on consumption, describing one of the more modern descriptions of eating disorders. He described a number of cases, but in particular, an 18-year-old young woman who presented with the following: lack of appetite, poor digestion, edema or swelling of her limbs, pale complexion. She was reported to have a lot of fainting spells. And he described her as having presenting with increased physical deterioration without a known cause, that is, without fever or cough, which were the primary medical symptoms, such as they were, that people would be looking for at the time. I mean, this is thought to be sort of one of the first modern descriptions of what would later become known as anorexia nervosa. Again, you can see that in this very distinct period of time. So now we're into the 1700s, or the 17th century rather. That this description of a patient would be very familiar to any of us today in terms of somebody who's presenting with an eating disorder. Sir William Gull coined the term anorexia nervosa in 1873, and similar to the other description, he was describing an adolescent who was emaciated. Her physical condition otherwise was normal, healthy respiration, healthy heart sounds, healthy pulse, but she presented with this total refusal of most food, was restless and active. And he described her as exhibiting a striking expression of the nervous state, for it seemed hardly possible that a body so wasted could undergo the exercise which to her seemed agreeable. Again, would be absolutely familiar to anyone looking at eating disorders in an adolescent in our current time. And one final historic example from World War II, Ansel Keys was conducting the Minnesota starvation experiment. So during World War II, we really had no idea what we were going to do with all of the prisoners of war coming back from World War II. We had no idea about the effects of hunger, and we certainly didn't know how to engage in refeeding. So he conducted this experiment where he took conscientious objectors who were volunteering for these studies, and put them on an extremely restricted caloric diet, and put them into situations like that would mimic the situations that they would be experiencing in the context of like a POW camp. What he found was, and also important to know, is that the men who volunteered for his study, so these were all men, first of all, were screened for any history of physical problems, any history of any psychological or psychiatric issues. So these were all men who had no history of anything notable. And what he found was, after a relatively short period of restriction, these men became nervous, anxious, apathetic, withdrawn, impatient, developed a distorted body image. Some even reported feeling overweight, moody, emotional, and depressed. A few even started to engage in self-harm behavior. In other words, they started to exhibit symptoms which, again, we would very clearly recognize in a different context as eating disorders. So, especially understanding that these men had no prior history of any psychiatric condition, let alone eating disorders, that they're not exactly in a high risk group for developing this illness, that the fact that we saw these symptoms developing very directly from just a period of restriction, again, told us something very important about the clinical sort of course of eating disorders and why we might be seeing some of the behaviors that we see. So these examples to me illustrate some particularly interesting characteristics of eating disorders. They're among the most homogeneous of all psychiatric conditions. That is, the presentation of eating disorders has tended to be fairly consistent, as I said, over time, but also from culture to culture, which is a rarity. Most things have some degree of variance from time and based on from one country to another, their presentations tend to look somewhat different. So that even though eating disorders seem to involve a relatively universal concern, I mean, I imagine almost all of us participating in this presentation, most of the people that we know. At some point, we've been concerned about our weight. We've thought about trying to lose weight. We've probably engaged in some sort of behavior, engaged in some sort of dieting behavior to try to lose weight. So even though the concern itself is a relatively universal one, eating disorders as a disorder still remain relatively rare. All of that suggests that there's what we would refer to as a common diathesis, that there's some sort of underlying condition to this illness that's present, that is somehow related to sort of our core condition as human beings. The presentation has remained consistent, and that's remained so despite the extreme prevalence and sort of our societal fixation, especially in our modern society, our societal fixation with thinness and with dieting behavior and quote unquote healthy behaviors, right? Even though that's something we're becoming even more fixated on societally, we're not seeing huge increases in rates of eating disorders. In rates of eating disorders that are presenting. So, we're really, even though eating disorders have been described and recognized for much of our written medical history, it's really only been in the last several decades that we've really started to engage in systematic and scientific investigations of eating disorders. They've not gotten much focus from researchers in the world of treatment until relatively recently. And so I think where one another place to start is to look at some of the myths about eating disorders. This, and when I say myths, I'm not just talking about the general public, but I'm also including many physicians, clinicians, people who don't necessarily specialize in this illness. Many of us, just from a societal level, carry a lot of myths about it and misunderstandings about eating disorders. This is something that I've been particularly proud of my association with NEDA over many years now. One of the most important things that I think NEDA has been engaged in is trying to dispel so many of these myths, because the end result of the existence of these myths mean that people aren't getting recognized as having eating disorders, and people aren't getting treated for something that could potentially be quite deadly. So the first myth I want to address is that families or mothers in particular cause eating disorders. This is a very old idea. Most psychiatric illnesses at one point are almost always blamed on the mother, blamed on families, and blamed on um, blamed in some way. This has been true for autism, for schizophrenia. And for all of these illnesses, we know that that's certainly not the case. Now, to be clear, there is, as I'll talk about it in a little bit more detail, we do understand there to be a strong genetic basis, but that's quite different from saying that families in some way cause eating disorders. In my over 20 years of clinical experience, I've seen I've seen incredibly supportive families and loving families and engaged families that produce a child with an eating disorder. And I've also seen everything to going to the opposite extreme of extremely unhealthy, toxic families that also produce a kid. There's no particular pattern to the kind of family um, that will result in somebody with an eating disorder. We understand that this illness is something that has a strong, as I said, a strong genetic basis. There are other environmental factors that also come into play, but it's not something that you can create. You can create in any kind of way. The second myth, which I think is also a particularly pernicious one, is that eating disorders are in any way a choice or just dieting behavior gone too far. As I said, the dieting industry and dieting behaviors are almost ubiquitous. Almost all of us at some point have engaged in those behaviors. The diet industry is a multi-billion-dollar industry, and it's only increased over the many decades. And what we're not seeing is a significant increase in rates of eating disorders. If eating disorders were just dieting behavior gone too far, we would certainly see significant increases, increasing over the last several decades, and we just don't see that. What that's more reflective of is stigma that's true for many mental health conditions, but something that seems to be particularly true for eating disorders. I think because mental disorders in general are not visible necessarily. that we don't tend to treat them in the same way that we might treat a physical illness that is more visible. We tend to look at mental illness as the result of some sort of constitutional weakness or lack of willpower or something, and we certainly know that that's not the case. These are very terribly afflicting illnesses for people. It's not anything that anyone would treat or frankly wish on their worst enemy. The experience of struggling with an eating disorder is extremely painful, and it's not anything that anyone would choose to do. The third myth is that eating disorders are just a problem of affluent, rich, white, young girls who are thin. And that's certainly in many ways the easiest myth to dispel. The average person with an eating disorder, that is by far the most common presentation of somebody with an eating disorder, is a woman in her 40s or 50s of any ethnicity with binge eating disorder. Now, that tends not to be the picture that accompanies, a blog post about eating disorders, a magazine article, if magazines are even still around, television programs, or any kind of more media depictions of eating disorders. We tend to we that tends to follow much more along with this myth about who struggles with eating disorders. Again, one of the things that I think NEDA has done a tremendous job with over the last decades is dispelling this myth that eating disorders afflict a particular kind of person. Um, we just know that that is not the case. Eating disorders can and do affect anybody, regardless of weight, regardless of gender, regardless of race or ethnicity, regardless of how wealthy or not wealthy that person is. None of those have anything to do with your likelihood of having an eating disorder. What it does reflect is access to services. When eating disorders were first being described in popular sort of culture in the 70s and 80s, the only people who could receive treatment at the time, because this was something that was still very much the realm of specialists and something that not a lot of clinicians knew what to do about. The only people who really had access to that kind of specialist was probably somebody who was affluent, who lived in a major metropolitan area, who therefore had access to those kinds of specialists, which tend not to exist in other parts of the country. So the fact that these specialists were seeing the same kind of kid started to become synonymous with what we thought eating disorders were about, and we just know that we've come to learn that that's not at all the case. And finally, that eating disorders are in some way caused by society and the media. Now, this is a relatively more complicated question. Similar to dieting, we certainly are seeing many more images, and we're being inundated with images of bodies and thinness and six packs and sort of what the ideal man and woman or what women are supposed to look like. There is absolutely, undeniably, increasing societal focus, especially on thinness. But as I said earlier, what we're not seeing is significantly more eating disorders being presented. Eating disorders existed long before the internet, long before even fashion magazines. And so, we know for many reasons that they're not anything that can be caused by media or society. Now, having said that, we do know, for example, that social media depictions of certain kinds of bodies are extremely harmful to especially young people. They're harmful to self-esteem. They're harmful because they increase levels of depression and anxiety. So I think there's all sorts of harm that sort of media images and societal images cause all of us more broadly. But I think that's different than saying that they specifically in some way cause eating disorders. So to put it in other terms, especially when I give this presentation or something similar to an audience of non-clinicians, I ask the following rhetorical questions. Oops. How many of us have ever been on a diet? But how many of us have ever been on a diet and actually loved it? And how many of us have been on a diet and loved it such that we chose the diet and dieting behaviors over being with our friends, over doing what we needed to do for school, over other relationships, over being with our family, over engaging in those activities that we enjoy and which give our lives meaning? That's the difference between somebody who just engages in dieting behavior, even if that might be a little bit out of control, and somebody who actually has an eating disorder. When you have an eating disorder, it becomes all consuming, and that becomes the focus of all of your energy. And you tend to quote unquote, you tend to engage in that behavior because of its drivenness, and leave all of the other elements of our lives aside. The reason that almost all diets fail eventually is that most people just give up on them because we go back to other parts of our lives. It's the difference between wanting to look better, which we know eating disorders are not, and wanting to be better, which we actually know that eating disorders are. Eating disorders arise from a profound sense of defectiveness. There's something wrong with me. I'm broken. I'm not as good as other people. I'm not as deserving as other people. I'm not as worthy as other people. And part of that is trying to change the way that one looks to try to compensate for that feeling. But it's not ultimately about wanting to look a particular way. It's certainly not about vanity. And what it really is about, what lies at the core of this illness, is much more this profound sense of I feel like there's something just very defective and wrong and broken about me. When we engage in treatment, what we engage in treatment with is that part of that person that has that terribly painful feeling, as opposed to trying to as opposed to engaging with something like vanity, which is nothing really to do with what an eating disorder is. So I'm not going to go too much into sort of the clinical symptoms, but rather to give more of a broad overview of what some of the signs and symptoms of an eating disorder are. There are emotional signs and symptoms: avoidance of strong negative emotions, significant amount of irritability, difficulty concentrating or processing information, um, apathy, that is not having particular um, uh, desire to do things, emotional and physical and social withdrawal, and expression of body image concerns. There can also be physical symptoms, sudden fluctuations in weight in a short period of time, and that can be either increase or decrease in weight. Feeling faint or cold, dizzy or weak, which is a direct result of malnourishment and some of the things like electrolyte imbalances that can happen when you engage in restriction or in binging behavior. Increased levels of fatigue and difficulty concentrating, and then a lot of behavioral symptoms that we might see, a significant amount of compulsivity or impulsivity. Um, Somebody who engages in dieting behavior or has chaotic food intake. Somebody who engages in excessive exercise to the point of exercising even when they're in pain or even when it interrupts other part of their life. A sudden shift in their diet, that is all of a sudden changing to an extreme vegan or gluten-free diet without being told to by, for example, a medical professional because they have something like celiac disease, for example. Someone who engages in frequent trips to the bathroom, who starts all of a sudden wearing baggy clothes, avoiding eating in social situations, we often see trouble sleeping as well. So now again, many of these symptoms are can be symptoms of any number of things, but sort of in total, when we see these kinds of symptoms in association with especially body image concerns, when we see them in association with excessive exercising or a significant change in diet, those are the kinds of things that might start to get us concerned about, is this person struggling with an eating disorder? There are any number of medical complications. This eating disorders are very serious illnesses with a high level of lethality, and it's because of the kinds of medical complications that we tend to see. There are a number of cardiac complications. It can impact on menstrual or fertility issues, neurologic and cognitive complications. It does a number of things to your GI system. It can increase your risk for things like type 2 diabetes and other glandular issues. And then other medical symptoms like issues with your eyes, hair loss, issues with skin, bone loss, osteopenia, as well as osteoporosis, sexual development issues, and many issues with the throat, and then other organ systems like the kidneys and the pancreas. As I said, eating disorders remain a relatively rare illness. As we get better with recognizing eating disorders, especially in groups that we typically don't see, some of these numbers have actually changed slightly. But at core, these remain relatively rare illnesses. The lifetime prevalence rates for anorexia remain about under 1% of women in their lifetime and about 0.1 to 0.3% of men in their lifetime. Bulimia slightly more prevalent, about 1 to 3% of women in their lifetime and about 0.5% in men in their lifetime. We see about 4 to 9% of college-age women will be diagnosed with anorexia or bulimia, and about 40 to 50% will exhibit subthreshold symptoms that are nevertheless of clinical concern. Binge eating disorder is actually the most common presentation of eating disorders. It affects about 2 to 4% of women and about 2 to 3% of men in their lifetime. We also see a significant amount of crossover, meaning that somebody with anorexia nervosa restricting type, a significant proportion of that of those folks will eventually develop anorexia nervosa binge purge subtype, and people with anorexia might go back and forth with periods of anorexia and periods of bulimia. I think that's one of the reasons why I think taking an approach that looks at all of these eating disorder categories together, because there are many more commonalities, as I'll get to in a minute, than there are differences. And it makes, from a treatment standpoint, from a core sort of phenomenology standpoint, it makes a lot more sense to sort of think about them as a group. Who is affected? It's still, especially with anorexia, we still see predominantly cis women and young girls being affected, although we are seeing increasing rates in males. And we also understand that we're not as good as at detecting eating disorders in cis men as we are in women, in part because of clinician bias about who it tends to be affected with eating disorders. The mean age of onset is around 17, but it's actually what we call a bimodal distribution. That is, there is one peak at around 14, 15, and another closer to 18, 19, which averages out to about 17. The reason why that's important is because if you think about what's happening at those ages, 13, 14, 15 is the onset of puberty and all of the hormonal changes that are happening in adolescence as one period of risk. And then around 18, 19, 21 tends to be when most of us are entering into young adulthood, having our first taste of real independence, and separation, having our first real separation from our families of origin, which is another extremely sort of stressful developmental period of time. So that there's this interplay between whatever someone's genetic predisposition might be and external factors like puberty or young adulthood coming into play. Of great concern, though, what we are seeing is increasing rates of body dissatisfaction in increasingly younger kids. Body dissatisfaction is a significant risk factor for later development of eating disorders. About 42% of first to third grade girls report wanting to be thinner. About 81% of 10-year-old girls report being afraid of being fat. And we're seeing rates of body dissatisfaction tripling in boys and men over the last decades, which is now almost equivalent to the rates that we're seeing in young girls. This is particularly concerning for a number of reasons. Poor body dissatisfaction has all sorts of things correlated with it, including increased rates of anxiety and depression. It does, as I mentioned, put someone at greater risk for developing an eating disorder later on, and it's a source of significant distress. I think much of that can certainly be attributed to societal norms and societal attitudes about valuing how we value thinness and certain kinds of bodies. Even more concerning are the rates of actual dieting behaviors that kids are engaged in. About 40% of 9-year-old girls have been put on a diet, 51% by the time they're 10 years old, and greater than 60% of high school girls will have been put on a diet. Dieting behavior, even if we leave aside the fact that they are almost 100% ineffective, um, they are, I mean, that should be a reason in and of itself, but we pay a high cost for engaging in those behaviors. There's a significant emotional and psychological cost even before we get to increasing risk for eating disorders. If you're somebody who is already predisposed to developing eating disorders, engaging in dieting behaviors is another precursor behavior that is going to even make that risk for you higher. So it's something that we want to be very careful of when I talk to schools and pediatricians' offices. These are the kinds of behaviors that we ask them to look out for. This is what we're going to see in somebody prior to them becoming somebody with a full-blown eating disorder. It's going to be excessive exercise. It's going to be engaging in pretty heavy amount of dieting behavior, and it's going to be a significant amount of body dissatisfaction. If one were to see, I would argue, any one of those to a significant degree, that's a kid that you would really want to um, have assessed for something like an anxiety disorder or an eating disorder. It's a very serious illness. It has now the second highest mortality rate of any mental illness. It's just been overtaken in the last couple of years by the deaths associated with opiate addiction. The lifetime mortality rates are anywhere from 5 to 20%. The mortality rate associated with eating disorders is 12 times higher than the mortality rate associated with all other causes of death for females 15 to 24 years old. Um, it's an extremely serious illness, and I think people tend not to think of it in that way. Um, and because it's so serious, trying to engage in better prevention efforts as well as trying to catch the illness earlier in its course is extremely important. Despite its seriousness, only about 1 in 10 people with an eating disorder will ever get any kind of treatment. And of that 1 in 10, only about a third will get treatment from a specialist. This really is an illness that requires specialized training and specialized clinicians to treat. All right. So, uh, one of the in thinking about eating disorders more broadly as a category, I think another really important way to another important framework to think about eating disorders that can be really helpful is to think about them as anxiety disorders. I'll be making the argument in the next several slides that for all intents and purposes, eating disorders really are anxiety disorders. That's part of why I'm here. I'm here today speaking about this, and on a number of levels, that statement is true. If we look particularly at anorexia and bulimia, and both of them are characterized by drive for perfectionism, high degree of obsessive compulsiveness, high degree of neuroticism and negative emotionality, a high level of harm and pain avoidance, low levels of self-directedness, and generally avoidant personality traits. So these are the characteristics that both anorexia and bulimia have in common. These are also all characteristics that are based in anxiety. These are all different manifestations of anxiety. Even when we look at some of the differences between anorexia and bulimia, for example, anorexia tends to be more characterized by high levels of constraint and persistence, whereas we think about bulimia as being more characterized by high levels of impulsivity, constricted affect versus emotional dysregulation, rigidity versus someone who's more sensation seeking, low versus high levels of novelty seeking, anhedonia versus more emotional extremes and emotional lability. What you've noticed with all of these characteristics is that even though they're on opposite poles, it's the same characteristics, the same underlying dimensions, which again are very much dimensions that are rooted in anxiety and what we understand about anxiety. They still are lying along those same underlying dimensions. We do know that eating disorders have a strong genetic basis, and that'll add to the anxiety argument as well. There's a strong genetic influence. About 40 to 70% of the phenotypic variants of eating disorders can be attributed to genetic causes, um, and and um, and we also see a high level of genetic inheritance pattern in other ways as well. The first degree relatives of somebody with an eating disorder are 10 to 20 times more likely to have an eating disorder themselves. We can look at twin studies where, for example, we look at what we call concordance rates. That is, what are the chances when one sibling has a particular condition that the other sibling will also have that same condition? So in monozygotic twins who share 100% of their DNA, we see a significantly higher rate of concordance when one twin has an eating disorder um, than we do with dizygotic twins who only share 50% of their DNA. And dizygotic twins or fraternal twins have a slightly higher concordance rate than regular siblings. So even though dizygotic twins and siblings both share 50% of their DNA, dizygotic twins are also sort of having a greater degree of sharing of their prenatal and postnatal environment as well. So this kind of pattern where identical twins have a higher concordance rate than fraternal twins who have a higher concordance rate than siblings, that's a classic inheritance pattern that we see in something that has a lot of genetic influence. We do understand that in eating disorders that genes have relatively more of an impact on the environment, but there's always an interaction that happens between the two. We know that if you're genetically predisposed, and that environmental influences can either increase your risk or they can be protective. For example, if you happen to be a kid who's engaged in a sport with a strong weight or appearance focus, that can increase your risk. If there's a lot of dieting in your own family, that can increase your risk if you're predisposed. If you engage in something like modeling or ballet, or again, anything that has where there's so much focus on either weight or appearance, that can increase your risk. If you're in a society or in a societal milieu, where there's a lot of focus on looks, which we certainly are. And if you experience a lot of teasing, all of these environmental or epigenetic risk factors increase somebody's risk for developing an eating disorder if they're already predisposed. But similar environmental things can also be protective. If you have a family that models healthy eating, that can be extremely protective. If you're in an environment that separates out self-esteem and body esteem, that can be very protective. You know, one of the positive things that we've seen in social media has been a lot of awareness around separating self-esteem and body esteem, and a lot of role models for body positivity and body neutrality. Really important conversations, I think, especially with Gen X and I'm sorry, especially with Gen Z and Gen Alpha, the younger folks are really talking about these very vulnerable issues about body esteem and self-esteem, and I think the bringing that out into the open has been extremely positive. There have been a number of media campaigns that have also been very good in terms of trying to separate those things out. If you have a strong role model for body respect and body esteem, if you have strong levels of family involvement, and sort of the opposite of teasing, if you have supportive peers, all of those can be environmentally protective factors, even if you might be genetically predisposed. All right. Another way that this is all really rooted in the same mechanism that is a part of what we understand anxiety to be, kind of has to do with how we interact with the world around us. So um, uh, all of us take in information either through our sensory mechanisms or our perceptual mechanisms. Our sensory mechanisms are just things like taste, touch, sound, sight, smell. So our senses. But then there's also perception, which is how we sort of make sense of what's around us. Perception is also, more importantly in this context, when we start to attach labels like threat or negativity to certain things. So, you know, most things are probably not neutral. Our experience, our life experience, kind of attaches some degree of meaning to most experiences as either positive or negative, as something that's a threat or not a threat. That's essentially sort of how we develop things like phobias and trauma and other kinds of anxieties. Is our perceptual mechanism has kicked in, and we have, for example, if I get into a car accident, something that might have been neutral before, driving a car, all of a sudden have my because I've gotten into a car accident, all of a sudden my perceptual mechanism has attached this very strong label of threat and fear to it, and now I develop a little bit of hypervigilance or a little bit of even a trauma reaction, even though I've been driving fine before up to that point, right? So it's sort of a basic way that we create emotions and anxiety. And it has everything to do with why we have emotions in the first place. Emotions exist to help us particularly deal with threats. We have to remember the threat the next time so that we can engage in fight or flight or freeze. We need to respond and recognize the dangers quickly and correctly. So emotions really evolve to help us do that. Emotions help us make those split-second decisions about whether something's a threat or is not a threat. Before our sort of frontal lobe, before our reasoning has really caught up, or even our memory has had a chance to process things, we have these automatic reactions to situations that tell us that we need to do something because it's been connected in some way to survival. And that's really how anxiety comes about. Our bodies still have that capacity. Our brains are still very much wired in this way. So even though we don't have the same kinds of immediate threats in our environment, right? We don't have predators lurking outside of our houses or outside of our apartment windows. We still have that instinct. So when a situation when the label of a threat gets attached to a situation or any other kind of stimulus, as far as our brains are concerned and our fear mechanism is concerned, there's no difference between there's a saber-toothed tiger ready to eat me at any moment, and there's this other situation that I feel a tremendous amount of anxiety or threat about. That's why when you have anxiety, when you have a phobia, when you have anything that's rooted in anxiety and fear, it feels as if you might die. It feels like it's a life and death situation. That's not somebody overreacting. That's somebody reacting exactly in the way that all of us have been programmed to react. And this all happens because of the functions of our amygdala, where our sensory mechanisms or our perceptual mechanisms can essentially sort of input into our amygdala, and it produces that automatic sort of survival response. So what does that have anything to do with eating disorders? Well, when you have somebody with an eating disorder, uh, another way to think about it is you have somebody who is predisposed to just being more sensitive, whether it's genetics, whether it's environment, or a combination of the two. That person has developed an extreme level of sensitivity. Anybody who's more sensitive is going to have more difficulty modulating their emotional response to things, which means that they're going to experience emotions, whether they're positive or negative, as subjectively much more aversive. Again, the way that we're all wired, if we experience something aversive, our natural instinct is to try to suppress or control or get rid of that feeling, right? If I touch something hot, my natural instinct is to move my hand away because I don't want to get burned. If I experience something that's negative emotionally, same thing. I want to try to avoid that or distract from that as much as possible because that's too uncomfortable. The problem is that when you over rely on strategies like worry, obsession, compulsive behaviors, even self harm behaviors, um, what ends up happening is that it just makes you more sensitive. The more sensitive you are, the more difficulty you have modulating your emotional response, the more the world starts to feel aversive to you and overwhelming to you, and the greater the drive to engage in these behaviors. This is essentially the cycle of eating disorders. You can start to, it starts with anxiety, and you start to, for whatever reason, attach behaviors like restriction, dieting behavior, exercise behavior, even binging and purging behavior, to try to manage your emotions around it. And the more you engage in those behaviors, then the more anxious you become, etc. You get trapped very much in that cycle. And we see other realms of overlap that are very direct. Eating disorders have ritualistic and compulsive behaviors, as well as obsessive thoughts around, for example, food and body. There are somatic symptoms that overlap with the anxiety disorders. There's an irrational belief system that has dysfunctional behaviors that you can't stop yourself from engaging in. And most importantly, what we've come to understand is that even after weight restoration, what we see left over is anxiety. Concurrently, about 55 to 62% of people with eating disorders also have at least one other anxiety disorder, primarily OCD and social phobia. And we also know, as I've said, that anxiety precedes eating disorder diagnosis. So in other words, eating disorders anxiety is there before the eating disorder symptoms have started. Anxiety is there to a greater degree during the course of an eating disorder. And even once the eating disorder has been managed, what's left over is anxiety. All of that really is to say that eating disorders are anxiety disorders. And I might do one more slide and then stop for questions. Okay, so um, uh, well, actually, that's probably a good place to stop. Um, w- if we see even apart from just clinically, I think it's tremendously helpful to think about eating disorders in this way, especially for families and loved ones. Unless you yourself have experienced an eating disorder, I think it can be very difficult to sort of imagine what that experience might be like. I think probably most of us can understand anxiety. And so to think about it, which is also happens to be true and accurate, to think about these illnesses as being rooted in anxiety also goes a long way in helping us understand what can sometimes be hard to understand. So with that, I will pause and take a few questions. Maybe I'll stop sharing.
Thank you so much, Dr. Kim, for such an impactful presentation. I'll go through the questions now. We had so much, so thank you everybody for your engagement. So let me just start at the top. You spoke a little bit about this, but would you say that eating disorders have to do with control, like trying to gain a sense of control? We had several
Yeah,
questions about that.
yeah. I think there's a yes and no. I think more than um, I think more than certainly control is an element of it. I think probably I would say we have um, overemphasized the control aspect. I mean, again, like in the context of this presentation, especially anything to do with anxiety, there's an element of control, right? If you're engaging in OCD behaviors, part of that is driven by a need to try to control sort of um, the fear that's coming up for somebody when they encounter a particular stimulus. And so the compulsion that they engage in is an attempt to assert some degree of control. So from that standpoint, it certainly is true. I think more than control is one element of it. I don't think it's sort of as core, and it's certainly not as universally present as we once thought it was. But it's definitely a big element of this illness. But I think it speaks a little bit more to kind of its roots in anxiety than maybe something specific to eating disorder.
Thank you. So we have several questions about what triggers relapse and how to support someone who is relapsing or potentially relapsing.
Yeah, that's such a difficult question to answer. I mean, it can be any number of things. Like, I mentioned two of the things that can really sort of kickstart the illness in a lot of people. I mean, if you think about any sort of major life event or any major stressor, maybe I think that's probably the better way to think about it. Anything that that could be considered a stressor for somebody, any major change, any of those things can trigger a relapse. Having said that, and the only reason I hem and haw about that a little bit, because that might sound somewhat obvious, is that for some people it might also not be anything in particular. It can be, I think not dissimilar to like substance abuse. It's not always a big thing that triggers a relapse. This is an extraordinarily difficult illness to live with. It's an extraordinarily difficult illness to treat, and it can be as simple as having uh, uh, having a particularly hard day in the course of treatment, and it's very easy to go from something like that to that's just a sign that I'm never going to get better. I'm not deserving of getting better, and why should I even bother trying? Right. So I think it can be everything from like almost, nothing in particular triggering a relapse. It's part of the momentum of this illness. And I think it's just speaks to how how difficult it is, all the way up to sort of big things. So, one of the things that we saw during COVID, for example, was that was the one time we did see a marked uptick in rates of eating disorders that were present because of all of the stresses that went along with COVID. That was kind of an extreme example, but I think that's the other end of that spectrum. So it can really be anything from, you know, sort of nothing you can put your finger on all the way up to, a significant loss, a significant change, to something that's a major trauma. It's really difficult to predict what's gonna result in a relapse or not, which is why it's so important that people continue to engage in some degree of, I'm not even going to say treatment, but that they have um, somebody and some sort of support system in place for themselves, whatever that support system might look like.
Thank you. So we have several questions about ARFID and the interaction with
Mm.
anxiety. So you could speak a little bit about that.
Yeah, so I mean, I will preface this with saying that RFID uh, is not my particular area of expertise, but there is a lot of overlap with anytime you see anytime you see a presentation that's rooted in avoidance, which is a core characteristic of RFID. Avoidance behaviors, extreme avoidance behaviors. I think as we've come to understand RFID better and better, it does kind of straddle that line between eating disorders and anxiety disorders. I tend to think of it more in line with something like more in line with other anxiety disorders than it is, even though there's superficial similarities to eating disorders, because if somebody is uh, is refusing to eat certain kinds of foods or only eating certain kinds of foods because that's their presentation, they're going to have the other things that come along just with malnourishment and malnutrition, right? So in that way, it dovetails into eating disorders. But I think just from a symptom standpoint, and from what we understand is happening, it's probably more similar to something like OCD, for example, than it is like an eating disorder. um, yeah, so it's very directly, related to it's very directly related to anxiety.
Thank you for that. So we have a question here. How do you find rates compare beyond like cisgender male and female, like non-binary, the trans community, for
Yeah.
example?
Yeah, that's a great and a really important question. So, relative rates, what we understand about relative rates, with the caveat that there's very little data on this, but in general, we know that rates are relatively higher in especially in the trans population for a number of reasons. The rates can be anywhere from a little bit higher to many times higher than in the cisgender population. That's a particular area of concern, especially with what's happening nationally in sort of the attempted erasure of trans folks and their identities, and just the lack of understanding societally, as well as the lack of understanding by treatment professionals, the lack of adequate treatment that's really tailored towards the trans population. I think what the little that we understand being that we know that that's a population that's particularly at high risk, and the fact that we have very little in the way of good sort of competent treatment, that's an area of particular concern for me and for many of my colleagues. And I really appreciate that question. I think it shines a light on an important area of eating disorder risk.